So from an inner metropolitan teaching hospital and LHD perspective, now to at least outer metropolitan, if not regional, LHD, Central Coast Area Health Service, Mr. Matt Hanrahan, who's the Chief Executive of that, will give us their perspective on work that's being done.
Thanks, Rowan. I would like to acknowledge the traditional owners of the land and pay my respects to elders past and present. I would also like to acknowledge all the nurses in the audience and wish you a happy International Nurses Day for Sunday. Would also like to acknowledge all the consumers and carers in the room. I think it's very important that you're here and you're working with us about the future. And I would also like to acknowledge our Medicare local friends and our friends from the NGO sector. I've seen a few today. A couple of people have said to me today, Matt, what's the story with the waistcoat? My wife said to me this morning, at least it might make you look a little bit more intelligent. I don't know about that. She also said Stuart Dowrick would look very sharp today, and indeed he does. So, what I'm talking about today is, are we ready for an admissions trading scheme? What does that mean? Some of you may have heard me talk about this before, and a lot of it is my own personal view, but let's carry on. So what do we know? We heard a lot this morning about what we already know about the acute and ED environment. We just heard a couple of people this morning talk about what we know about hip replacements, the cost, and we break it down to a unit level. We can break it down by length of stay, and Brian spoke about clinical variation, unwarranted clinical variation. We've got a pretty good idea of where that's happening and getting much better in learning why, and we can compare ourselves at a local, state and international level. What are we working on? We've heard today about what we're working on, about subacute, around mental health, not admitted activity, and again, getting that data, breaking it down by the cost units and doing comparisons. The issue around quality and safety, again, it's been discussed this morning, still a fair bit of work to go in relation to that area. Where are we heading? One of the passions of mine, I spent a bit of time in the space in the primary and community sector before coming back into the public system. And I think there's great opportunities, and we've heard a lot of discussion today about Medicare locals working with the primary care sector, but we need to have a much better understanding of what the costs are, what the benefits are, and how we can make it work. So key focus areas and what we know about ABF. We know that costs follow the patient. We know it's about efficiency and equity, and we heard that today. Quality and safety, we heard that again, reinforcing it. And we've heard a bit about governance and structure and devolution, and I think Carol's presentation about what's happening in LHD is really important, and I think a lot of it is generic in terms of what all LHDs are doing across the board in education, getting clinical buy-in. I take the point this morning about culture. It is critical, and we all need to take responsibility for it, and I agree that it's about all clinicians, and not just clinicians, but consumers and patients need, obviously, and carers need to be part of that. It's about communication, we've heard about that, and it's also about evaluation and research, about what does it really mean when we spend a dollar, what do we get for it? And I get someone raised the point this morning about we have to be smarter and braver about what we disinvest in. So what does it mean? We've heard about the 4 R's, and we also heard today, about right care, right place, right time, right person the first time that Brian said. I think we need to include the right price. We have an understanding of what a COPD admission costs us, and we know the variance that it costs. But do we know what it really costs to treat that COPD admission in a hospital in the home environment, or to work with general practice and other providers in the primary care to get a better, an equal or better outcome? But what does it really cost us? And I don't think we really know that yet, and I don't think we're really at the point, but we need to get there quickly to understand what those costs are so we can make smarter decisions about investment and or disinvestment. Again, the acute sector primary care semantics, and we've heard a lot today about different semantics between the national, state, and if you go out into primary care and general practice level, you've got a whole other language altogether, let me tell you. You also have a different system. You have a system in general practice predominantly based on fee-for-service. So the challenge for us is how do we take a model of ABF and case mix, which is about funding for what we do and the outcomes we want, and translate that into an environment either in the NGO sector, through Medicare locals and in general practice that's sustainable and really identifies what we're purchasing and what the outcome is. Key players, we've mentioned it before and we've heard it this morning, patients and their carers, and I guess we all agree here today that patients and carers are absolutely at the top of that. And I guess it's going to be really interesting to look at the NDIS and how that rolls out. And I think we'll get a lot of learnings from that And I'm really keen how that works in the Hunter, and I know Michael D'Orenzo up in the Hunter, New England, will be keeping a close look at it and feeding back to us. But I think there's some good learnings to have. Hospitals, obviously, and we mentioned public and private. I know last year, just through part of the winter strategy, I purchased services from a couple of our private hospitals on the coast. And it was much easier to negotiate because we had a better understanding of what it costs us locally, and to have a better negotiation what we were buying, because there was a common language, and certainly the private sector have a very good understanding of what their costs are. Medicare locals, a lot's been said about Medicare locals. We've had a very strong, long and successful relationship with our Medicare local on the Central Coast and have been doing lots of collaboration. But I think we've got to go the next step to really get that maturity about sustainable business models. GPs, Aboriginal medical services, and great opportunity. We're developing an Aboriginal health plan on the coast. It's not a Central Coast LHD Aboriginal health plan. It's a Central Coast Aboriginal health plan in partnership with the AMS and the Medicare local. NGOs are playing a much bigger part, and it's interesting, and another thing to be watching and learning from is I guess the reorganisation that is happening at a local and state and national level around NGOs, where we have some very small NGOs who manage on a budget of $1 million to some very large non-for-profit organisations that are national and have very large infrastructure. Private providers are a key player in all this, allied health specialists across the board. Councils, I think we shouldn't underestimate councils, particularly in around health promotion and prevention, and particularly around planning. I know in our area, in the north part of Wyong, there's lots of population planning going on and looking at facilities. How do we build that into an ABF and other government agencies? And I think the DG mentioned this morning about work with community services, and particularly on the Central Coast, we're doing a fair bit of work with the Education Department and one of their strategies, which is around schools and communities. How does that translate into an ABF environment? So innovation, it takes innovation. We all know that, and a lot of people in this room, probably everyone in this room, is keen to be innovative. We need to be able to measure outcomes. We need sustainability. We obviously need consumer buy-in. We obviously need clinician buy-in. We need leadership, investment and evaluation. So admissions trading scheme, that interface between the acute sector and the primary care sector. We need to understand a price on admission, and we know in our service agreements, we've actually got incentives to reduce readmission rates within 28 days. And if you start unpacking that data, it gives you very interesting information about what we need to do to be more efficient. But what are we actually going to buy from the primary care sector, and do we do that locally? Do we do it internally, or do we actually go out to the marketplace? We need to do it on a contract management basis. There needs to be a strong business platform and model for us to know what we're purchasing. If we look at the chronic disease program, if I want to reduce a person who has 8 admissions a year and I want to reduce that by 50%, and I purchase that from a Medicare local, I don't want to be paying twice for an admission. So if Matt is admitted that 5th time, then I'm paying for that admission, but at the same time I'm paying for a hospital avoidance. How do I do that? How do I know I'm going to get the outcomes? And how do we measure opportunity cost? The issues that's been discussed earlier about quality, clinical governance is critical in this, particularly between the LHDs, GPs, specialists and NGO providers, and obviously corporate governance. So pay for performance, we need to incentivise, and we heard today, and the ABF allows us to do that. There are incentives to be efficient, but also it's that issue about, do we let inefficiency continue on in the system? And we've seen the slides today about hip replacements, etc. And for me, there's a couple of key issues. Where does prevention fit into ABF? Health promotion and prevention. I don't have the answer, but I think it's critical, because if we're going to spend $1 in prevention, it means we don't spend $1 in treatment. And how do we know we're going to get the best outcome? There's a lot of work that's been done. There's experts who know a lot about this more than I do, but I think it's a conversation we have to have. And for me, it's always about opportunity cost. And whenever someone comes to me and says, Matt, I need another $1 million to do X, Y, and Z, I said, that's okay. What if we took $1 million off another service? What would be the impact? And do you have in your bottom drawer the services that you're going to disinvest in to be able to fund the services that you know make a difference? So in wrapping up, I guess we need to be brave. We need to take the next steps. It is based on data. Patients need to be at the forefront, and we need to look outside, I guess, our traditional models and take the challenge on. Thank you.